Okay, so let's go ahead and continue. So now we're looking at a situation where there is possibly pneumonia. And as we know, pneumonia can be caused by many different organisms. It's not always going to be bacterial, but a lot of them really end up being bacterial in nature, or it could be some virus. But what we expect to find with any kind of pneumonia, they're going to always describe it as a consolidated process. So we look for white. So like in the case of the film on the right side here, aeration in the lower lobes, but no aeration happening in the upper lobes at all. And so we gotta suspect that this has got to be consolidation that's taking place. And it says here, then the last bullet point is that you might end up with some hilar adenopathy or lymph adenopathy that's associated with the pneumonias as well. So, like in this X-ray here, we don't see the obvious whiteout or consolidation, but there's enough infiltrates where they're possibly suspecting that maybe there is some beginnings of pneumonia. But what's really of concern is how the lymph material here is looking really engorged. So that overactive lymphatic system, or as they're calling it here, hyadenopathy, could be a pleural effusion associated with pneumonia as well. Like in this example, the costophrenic angles look to be pretty distinct. So I don't really see anything that would look like possible fluid accumulating out in the pleural space. But on the film here on the left side, there could possibly be. Well, that is maybe not all of the lower lobe. Maybe that's like only partial. And then the rest of it is being obscured by fluid. And then only on the one comment I wanted to make about these two pictures. I'm looking really hard and I can't see anything that looks like a radiopaque line on this film. And then I look over here, I also really can't see anything that would look like an ET tube. I see something in the airway or maybe in that region, which could again just be a feeding tube, but it looks like it disappears. I think this is the beginning, and then here, and then I don't see it anymore. But then I look down further, and now I can pick it up again. So this is the feeding tube that's going into the stomach. And then these little white circles right here, this was a heart baby. So all of those congenital heart defects that you studied, this baby had to have surgery to repair whatever it was that he had. And this is the classic kind of like they use these like these I don't want to call them sutures, but these are the things that they're going to insert, and and then after everything is healed, then these will be removed like staples or clamps, or whatever you want to call them, and they show up as white. And anybody who's had any kind of heart surgery, if they still have these inserted, it's going to show up like this on the film. Asthma. Now, if you get an X-ray for someone who has asthma, you may not see what you think you're going to see. But if it's really bad, you may get air trapping on that film. And air trapping is usually really dark. And the bronchial wall thickening, you have to have a pretty good eye. You have to, of course, be trained in x-rays and to be able to really detect when there is some thickening of the bronchial walls. If there's substantial mucus plugging, then that could lead to air trapping. And then the mucus plugging could turn around and also cause atelectasis because the air is not making it to the alveoli anymore. And then with these babies, these pediatric patients, they could end up with a pneumomyostinum with asthma if it's really that bad. But I'm saying all this to say, notice that I didn't include an X-ray here because you don't just think X-ray. You think this is probably a patient who has asthma. The next thought isn't, let me get an X-ray to confirm that there is asthma, because it's just not really going to be that it's not going to be that remarkable unless you got something like this, like air trapping and atelectasis. Cystic fibrosis. Now we know that when it comes to the obstructive lung diseases, this one is pretty bad because you've got this continuous, extremely thick mucus that's being produced, and it's leading to a lot of mucus retention, or a lot of retained secretions. And over time, it could get so bad that it transforms into the bronchiectasis. And so that's one of the things that you would expect to see on X-ray with someone who's got really bad cystic fibrosis. You'd expect to see a lot of just like atelectasis. And also you could see if there is any kind of like air trapping going on, you should see areas where there is really dark. So almost like a mixture of these kind of issues. You've got the air trapping, and then you also got the atelectasis on top of that. And then the rest of these points here are just saying that as the cystic fibrosis gets worse, and it does, of course, it progresses. You know, no matter how much treatment and whatever you're doing, you're still going to end up progressing through these different stages until it gets to the point where you may have to consider a lung transplant. And mostly because of all the scarring that happens over time. And then ARDS, now we're saying acute respiratory distress syndrome. Back in the day, they used to call this adult respiratory distress syndrome. That was mostly, I believe, just to try to distinguish it from adults versus children. But they kind of did away with the whole adult respiratory distress syndrome and just said acute. With neonates, they have just RDS, or respiratory distress syndrome. So we don't have to even like distinguish whether it's acute or whatever. It's just respiratory distress syndrome. So with any pediatric patient who has developed, say, pneumonia, and the pneumonia isn't getting any better, or they were like a victim of almost drowning, like a near drowning kind of situation. There's a lot of water now inside of their lungs. So really, any lung injury is what this is really saying here. ALIs, just acute lung injuries, is what we know could easily lead to ARDS. And then, of course, pneumothorax. It could potentially spiral into a situation where there's a ARDS as well. More on ARDS in the next course, or the last course that we have in a couple of weeks. And then chest trauma, of course, with this particular picture here, if you saw this, then you can almost anticipate what you're going to find on X-ray. So what could possibly happen? This unfortunate, I mean, if we're going to try to say, identify possibly what happened, maybe this was a sibling, and the sibling was playing with this pen with the baby, and then accidentally poked the baby in the chest, and then of course mom rushed the baby to the ER, or mom rushed the baby to the ER and didn't want to even take any chances of pulling this pen out, and then you go from there. So what could possibly happen? I mean, this will be a classic kind of like a penetrating type of trauma. So it's not just a blunt force trauma, but it's literally penetrating the thoracic wall. So when you look at the X-ray, it will just really kind of depend exactly what kind of injury or what kind of trauma the child experienced. So any kind of like tears and openings and things of that nature, you think air is going to be able to now rush into the pleural space, and then you end up with a pneumothorax. And then if the blunt force trauma was severe enough, it could have probably cracked the ribs and caused some rib fractures. And then the child ends up with the classic kind of like a flailed chest situation. And then if you look at the x-ray and you see that the heart looks to be a whole lot larger, then that's just the response. I mean, that's just a natural response to injury. You've got now the heart itself is starting to enlarge. And then I also forgot to mention that, of course, if there's some internal bleeding, blood will show up as white. So if there's a lot of hemorrhaging that's taking place, that film will show a lot of radiopaque areas where the blood is collecting. Now we get into chapter 22, and then we'll just kind of go through each disease and look at the indicators, if there are any indicators, or not necessarily indicators, but look to see if there's any there's any causes. So we're looking at the etiology of these different types of problems, and then we talk about options as far as what can you do to support them and to treat them, and if they are responding like they're supposed to, what would you expect to see? So here we go with RDS, so respiratory distress syndrome. Now, 1% doesn't seem to be a large figure, but when you think about how many people that we're talking about, and I didn't see otherwise, so I'm thinking that this 1% is just representing in this country. The smaller the baby, the higher the chances of developing RDS. So as you see, this is definitely a small baby. This is definitely an SGA kind of a situation. And they placed an ink pen right next to him just for perspective to see just how small this little one is. And then we already looked at this in another chapter as far as the antenatal assessment that we do when we're looking at what's going on with mom to kind of predict what's possibly going to happen when the baby's here. So mom ends up developing diabetes and et cetera, et cetera. Precipitous delivery is just another term that they use for a very, very rapid delivery. So we know that labor is supposed to take place over time. It's supposed to be over like hours. But a precipitous delivery, sometimes mom has no heads up at all. Maybe she starts to feel like a contraction, and then in the next second, the baby's being delivered. And that could be not good for the baby to be delivered that quickly, and not good for the mom either, really. And then et cetera, et cetera, et cetera. So all these things that would be considered like high risk, it will possibly lead to RDS when the baby is born. So now, any baby who is less than 28 weeks, if they are producing surfactant, it's nowhere near mature yet. So it's pretty much ineffective. And we know, as we saw in the previous chapter or yesterday, surfactant therapy, you may have to go ahead and do a rescue dose right away to kind of get them in a better situation. And then overall, the pathophysiology, what you expect to see with RDS, lots of atelectasis, poor FRC, lung compliance is not great. And then as far as the cardiac and pulmonary, or the pulmonary vascular resistance, there's usually going to be much higher pressures. You've got way more resistance to blood flow. And then that's going to ultimately lead to a VQ mismatch situation or shunt. Now, we had a statistic that said about 1% of the all births are going to possibly lead to RDS. Sometimes, no matter what, this could be an AGA baby. And if it's in the genes, then he or she still may end up with RDS. The last point here is saying this is kind of like nature's way of trying to help the baby out. So if, say, you've got a definitely premature fetus, and mom has been under a lot of stress, and those stress hormones that she's producing, they're going to make their way across the placenta into the baby's system, and then that will stimulate more surfactant production. So it's kind of like a way of saying, if mom is this stressed, then labor will probably start to happen at some point very early than what it should have been. So then that way, maybe your baby will have a better chance, possibly. And still, you may have to step in and do some surfactant therapy. As far as the presentation with RDS, what do we expect to see? It's just like with ARDS, this is a definite problem with the lungs. So oxygenation is going to be a problem. Ventilation will be a problem. As we said, compliance is really poor. So what would the baby do? And they're going to breathe faster because it still comes down to minute ventilation. You still need a certain amount of minute ventilation. And if your lungs just aren't really expanding like they're supposed to, then you're going to have to end up breathing faster. The grunting, that's of course, baby's way of trying to produce this like a back pressure, which is kind of like generating PEEP to try to reverse the atelectasis, trying to really increase the FRC. Flaring, as we said, is a way of trying to increase the diameter of the nares. So that way, a bigger diameter would mean better gas flow. So if you didn't flare while you're breathing in, it would be even harder to try to get the air into the lungs. And then, of course, retractions. Retractions we definitely can associate with increased work of breathing. They show up a lot more on newborns because of their soft, cartilaginous type of like ribs. The ribs haven't really had a chance to harden yet. But even still, a retraction is a retraction. It means that you're working harder to breathe than you should. Potentially unresponsive to stimulation. If you've got a baby who's very premature, the last thing you want to do is overstimulate them, because that would limit their ability to get better and to grow like they're supposed to. So there's a whole big thing out there where nurseries are always trying to find a way to keep that environment as quiet as possible. And then there's thing called touch times. Your babies are not supposed to be touched all the time, meaning that you have to bundle your care. You in nursing, if you're going to have to go and give the baby something, give the baby medications or take blood or whatever the case may be, you need to sync with the nurse's schedule as best as possible, so that way you're both going to be able to do your care pretty much at the same time. Just have to be one after the next person. And then the rest of the time would be like hands-off time, and you're not supposed to be touching this baby at all. Breast sounds, as you would expect, they're going to be diminished. And yeah, the refractory hypoxemia is real because of the changes in the lung. I mean, you don't have enough surfactant, or the surfactant is very immature. You have the lungs that now do not want to inflate because of all this increased surface tension. And then that will lead to, of course, some major oxygenation problems. As far as the ABGs, you could see definitely acidosis, but it could be also a metabolic problem as well, because it's complicated, really. We mostly try to just focus on what's going on with the lungs, but you got to remember, when it comes to like respiratory distress, whether it's ARDS or just RDS, it's really a complete system. And the entire systems, all the different systems are not really doing that well. So that would mean like renal is not doing that well. The ground glass is characteristic of any type of RDS or ARDS. And then the LS ratio, greater than 2-to-1 is good. That's mature surfactant, but anything less than 2-to-1, like a 1.5 to 1, that's immature surfactant. And there's a picture of a closer picture to kind of show this. If you look at it, it looks kind of like that glass, like they install in your shower sometime, that frosted kind of glass, or the window may look kind of frosted, and you can kind of see through it, but not really. And then those arrows there are saying these are air bronchograms, meaning that they show up because of what's going on. I mean, normally, of course, we know air is inside of the airways, and it would show up as black. But usually, there's not enough contrast to be able to make them out this clearly. So anytime that there's these little what they call air bronchograms that are kind of showing up over in different places of the lung, then that's also characteristic of like an RDS or an ARDS. You got now the opportunity of all this hazy white to kind of act as almost like a white background, and then you've got your black represented by the air inside of the airways. So then before I go any further, doesn't look like this baby is intubated, but there's our feeding tube. So this feeding tube, instead of just seeing the one radiopaque line and then there's that little gap here and then the rest of the feeding tube, you can kind of see the other side of the tube as well. It kind of shows up a little bit here and then shows up there, which just means that it looks like the tube is a little bit twisted, which is not that big of a deal. And it's in the stomach where it should be. Now, how do we try to stop RDS from happening? Well, they give some recommendations as far as, you know, the whole C-section thing, poorly timed C-section. Now, sometimes you can't time or you can't really schedule the C-section like you would like to because something happens like an emergency situation, then they have to just do it in a C-section to save the baby. And then the fetal heart rate monitor, that's something that they really want to keep track of before delivery. So let's say antenatal and intrapartum fetal monitoring is going to be important. And definitely, if you know the baby's going to be born premature, they got to get mom started on those steroids as soon as possible. And that, of course, as we saw, will help to accelerate the production and the maturation of this surfactant the baby's producing. Now, how do you treat the baby? So all of the things that we did to try to avoid it, and it didn't really work. So he still has RDS. So then we have to, of course, we got to deal with the ventilation and oxygenation, which means that you're going to have to do either like CPAP or like a BiPAP. And we'll talk about what BiPAP is for babies because it's not really BiPAP. Or you just do full-blown CMB. Because of all this haziness that you see on the X-ray, which represents fluid balance is something they gotta achieve. They gotta do their best to try to achieve an adequate fluid balance when it comes to intake versus output. And as we know, surfactant, whether you choose CuraSurf, InfoSurf, Surfanta, whatever, you're going to need to consider giving, and it may take more than one dosing. And then just watch monitor like any other patient. You're going to monitor all of the vitals on a regular basis. Everything is usually there on the monitor. You've got them connected, so that way each time you go in and do an assessment, everyone's going to be able to keep track of what's going on as far as the vital signs. BPD, so I refer to this as like the baby COPD. So this is definitely chronic. Now, hyaline membrane disease. So once again, some authors are going to refer to RDS as HMD, which is hyaline membrane disease because of how the tissue looks under the microscope. So if you took lung tissue from a patient who had RDS and then you stained it, it will stain like, like it'll stain reddish. And then it looks like a membrane, more or less. So they call it hyaline membrane. But again, most people are just going to refer to it as just RDS these days. So here's how it starts off. You had to place this baby on the ventilator because just O2 was just not enough because of the extreme refractory hypoxemia and the acidosis, the respiratory acidosis. So then you place them on CMV, and now the lung is going to end up essentially just getting destroyed by this ventilator. You've got a very premature baby to begin with, whose lungs were not that great. And now the ventilator is just wreaking havoc and causing more changes for the worse, unfortunately, in BPD. So then we got these four factors here. Very, very immature lungs, respiratory failure. You had to give a lot of oxygen. So we know O2 toxicity is something we're always striving to not reach by giving as little oxygen as possible. But then sometimes you may have no choice but to give more oxygen than you'd like to. And then over time, that's going to cause damage to the lungs. And then positive pressure ventilation. So again, that ventilator is probably doing the most harm than it is good for a baby this immature. But then your hands are kind of tied. Like, what else could you do, really? So your only recourse is to try to get them off the ventilator as quickly as you can. And it may be easier said than done for some of these, especially the really, really small babies. Now, BPD, when you look at the x-ray, I mean, this kind of looks like just your classic kind of like RDS, where you got like the haziness and the ground glass kind of appearance. But if you're seeing this, and it's a ventilator situation, the baby's been on the ventilator for like a week or 2 weeks, and you're seeing this, then you connect the dots and say, it's been a couple of weeks since the baby's been on the ventilator. This is the x-ray that we're seeing, so pretty much the baby has BPD now at this point. One other thing I wanted to point out, well, first of all, here's the ET tube, and this one is pretty clear. That radiopaque line, it looks to be really, really dark here, or really, really white, which is how it's supposed to show up. In fact, you can see the entire ET tube. Here's the radiopaque line, there's the bottom of the ET tube, and there's the other end of the ET tube. And as far as placement, it looks to be a little bit too low. Here's the left clavicle, there's the right clavicle. The border should be just slightly below. It looks to be a little bit maybe too low, but then look at the baby's head. It looks to me like the head is turned a little bit to the right. And also look at the size of the clavicles. This clavicle looks to be a little bit bigger than that clavicle. So overall, the baby looks to be not lying flat, maybe completely either. All right, so then Other things here again is the feeding tube or the OG tube. Now, and then the EKG leads. Now, you can even see the blood pressure cuff. Looks like they've got a blood pressure cuff around this baby's arm. And then, what is all of this? It looks kind of odd, but that would lead you to believe that there's possibly this may be just like is it maybe like a blanket or something that got picked up on the x-ray? Because it looks to be on this side as well. Or is it really something going on with the tissue? I would be leaning toward maybe this is just something else that got caught up in the picture of the when they did the x-ray. Now, how do you prevent the baby from ending up with this chronic problem? Because once they do end up with BPD, even after you get them off the ventilator, they are all over the place as far as their saturation. So you'll have them on just like some supplemental oxygen, maybe just like a cannula. And then 1 minute, the pulse ox is alarming, saturation is too high. And then in the next minute, it's alarming too low. So they go literally from one extreme to the other, like almost constantly. So then how do we try to treat them? You know, again, we try to minimize things like don't give too much oxygen and try not to place them on the ventilator. If you do have them on the ventilator, use your protective lung strategies, just meaning that you're going to always be trying to give the bare minimum oxygen and you're not going to be using too high of pressures. You still need to ventilate adequately and you need to treat the atelectasis and so forth and improve compliance. But there's a limit that you want to kind of think about as far as if I use a standard pressure, then this baby probably really will end up having BPD at some point. So you may have to back down on your pressures. And once again, the INOs are going to be monitored very carefully. And any kind of like fluid overload situations, or not fluid overload situations, but anytime that you really are seeing prominent fluid on the x-rays, then they're going to have to, of course, give diuretics. As far as the lungs themselves go, we know that to deal with all of that swelling, you're going to need to think steroids. So they got to be given steroids, whether it's IV or whether you nebulize them. And in most cases, they're going to end up having both things done. They're going to have nursing give the IV steroid, and then you're going to be nebulizing steroids and giving it to them as well, either like an MDI or an actual nebulizer, like with the small body nebulizer. And you have to connect that into the ventilator circuit. So then bronchodilators, of course, as well, whether it's going to be MDI or aerosolized. And then pulmonary vasodilators could help with decreasing that PVR. That PVR is mostly because of the oxygenation challenges. So if they're hypoxic, the pulmonary vessels will constrict, and then that's going to lead to VQ mismatching and even more hypoxemia. So a lot of times you have to think about a pulmonary vasodilator. This will be a classic situation where you would check to see if maybe you could use inhaled nitric oxide. INO will be probably like your first go-to, being that it's a selective vasodilator. Now, TTN, so transient tachypnea of the newborn. So as we saw, this is something that usually is not a big deal, and it will most times just kind of fix itself. And when we see TTN, it usually is because the baby wasn't born naturally and didn't get that normal squeeze that they were supposed to get. And that will usually take care of this fetal lung fluid. Most of the times you're going to find that it may be your term babies. Even if they were born naturally, they still may end up with a little bit of that fetal fluid still there, and they may become tachypnic for that reason. But the last point there under the incidence, just to say that even though you mostly will find it in the term babies, the preemies will end up having this problem as well. Again, especially the preemies had to be born like through C-section. So the pathophysiology is just saying if they weren't born naturally, they didn't get a chance to get that fluid squeezed out. And then the cord clamping, again, that's just such controversy these days. Like, when do you clamp the cord and cut it? Do you do it right away and risk the baby being a little bit hypovolemic? Or do you wait a little bit of time, and then that way all of that blood in the placenta will now have a chance to be taken up by the baby, and then you clamp and cut, and so forth, et cetera, et cetera. And babies that are, I mean, male babies are possibly going to have TTN a little bit more than the female babies, or the boys versus the girls. But again, that's not really in stone. It's just that they typically see a little bit more of the boys having this than the girls. They've linked something with the mom, like moms who were asthmatics. They typically had more TTN type of babies. And then the macrosomia, which is of course like the really, really, really large babies, you know, the huge, huge babies, they sometimes end up with TTN. And if you've got a set of twins, or a set of triplets, or a set of quadruplets, they may all end up with TTN. Now here's again what you'd expect to see as the same X-ray we had in the other chapter, more or less, just to kind of show that you see black, but you don't see complete black, and you see a little bit of extra white going on, which could be that leftover fluid, and then there may be a small bullet effusion associated with that as well. And then when you're looking at this baby, here he or she is just breathing really, 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 really fast, and grunting. That's one of the things when you say are expecting the baby to continue to transition like they're supposed to, they shouldn't be grunting as they're transitioning. So if they do start grunting at some point, you got to consider that maybe there's TTN. So grunting, in addition to retractions and nasal flaring, all of those will just mean that you're going to have to admit the baby to the nursery and support them, and then see what happens the next day. So as far as what do we do, you could just give like oxyhood. You can just place them on like a 40% oxyhood, 30% oxyhood, and then can of course monitor them and see how they do. I think some people call this a head box, this oxyhood. Or you may want to do CPAP, because with positive pressure, that's going to force the fluid out of the alveoli, and it's also going to keep the fluid from moving back into the alveoli. So pneumonia, as you see, a lot of babies end up with pneumonia, and mostly because of like that group B streptococcus that mom is normally colonized with. So during the birthing process, the baby probably got exposed to that GBS. Now, if they identified GBS early on, they already had mom on antibiotics probably. Oh no, I take that back. If you identify group B strep, then you're going to be on the lookout for possibly the baby maybe developing pneumonia. But then there's some other things, of course, you know, there's E. coli, there's staph, and et cetera, et cetera. So a lot of this can be the baby developed pneumonia because of during the actual birthing process, or it happened after birth. And it was just the environment and possibly maybe us not being careful and following, the standard precautions and things of that nature. And then the babies who are discharged home, and let's say that at home, it's not maybe the cleanest environment. They could possibly pick up something from there or pick it up from one of their other siblings as well. So really this kind of goes like inside of the hospital and on the outside. How does the baby end up with pneumonia? So then again, how does it happen? A lot of times it could happen like in the case of PROM. If the membranes ruptured too early, now there's really nothing to protect the baby. And then some of these organisms that are already there can just migrate and make their way and affect the baby. Now, what are the risk factors that we expect? Let's see. We expect really small ones to be possibly developing pneumonia. So they're going to be almost at risk for everything. They're going to be the highest risk for developing RDS. They're going to be also possibly at risk of developing TTN, which is not bad. Then they can also end up developing pneumonia. So with pneumonia, it's what you expect. You expect them to be tachypnic, tachycardic. And if you did APGAR scoring, their APGAR scores may be showing that they're not doing that well as far as transitioning. And then other things, as far as that kind of like unexplainable, like why is the baby really not feeding, and a little bit sluggish. It looks a little bit more sluggish than he should be looking, and et cetera, et cetera. So all these things are just pretty much going to be red flags to say that that's possibly pneumonia that's set in. So then how do we try to keep the babies from developing pneumonia? Or once they do develop it, what do we do for treatment? So this is not really out of the ordinary when it comes to just the run-of-the-mill pneumonia. You're gonna try to, like, of course, make sure that while you're carrying the baby mom, you have to follow a good diet, take your supplements and try to exercise, all the things that they're always encouraging you to do to try to like minimize the chance of your baby from having some kind of problems. And then once the baby has been diagnosed, then you're gonna have to start some kind of antibiotic therapy or antiviral if it is not a bacterial type of infection. For the hypoxemia, then we know we have to give oxygen, whether it's, again, you could do like a hood, or they make cannulas in very, very, very small sizes. You got like literally different sizes of baby cannulas. You've got like for the really, really small micropreemies, and then you've got for like the standard size baby. It's just that when you place a cannula on the baby, you have to, instead of placing it around the ears and then underneath the chin, and then using a little chin adjuster thing, you have to kind of place it in their nair and then tape it on their cheeks to keep it in place. And then ECMO. We'll talk about ECMO in the next week or the last week. But either way, ECMO is something that if your facility has the ability to do, it's something that you may have to consider, especially in those extreme oxygenation problems. But most times the pneumonia is not going to lead to that kind of an extreme situation. Could be possibly some other things going on. MAS, or meconium aspiration syndrome, this, as we saw before, it can lead to a lot of problems. It can lead to air trapping. It can cause a lot of atelectasis as well. But when we get down to the bottom of it, what it really is the baby has unfortunately aspirated some of his own excrement, his own bowel contents. The more the baby's stressed out in utero, the more he's going to poop. And now that poop or meconium is just floating around in the amniotic fluid, and he's still practice breathing while he's in there. He's still, going through the motions of breathing, even though it's just fluid going in and out of his airway. And that just means that now you got a chance of this meconium getting lodged and getting stuck down in the lower airways. As we saw in the surfactant chapter, meconium inactivates your surfactant or breaks it down and makes it pretty much ineffective. And then we know with meconium or any bowel content for that matter, there are a lot of anaerobes in your digestive tract that are there to ensure that things are broken down like they're supposed to. That just means that you've got now something like E. coli, for instance, that's normally in your bowels, it's in your lungs. And we know meconium aspiration can easily cause a severe infection or a lung infection. So now here's that air trapping situation that can happen in MAS. So first, let's say that we realize that mom is under a lot of stress and she's been having a lot of issues. Then if she's under a lot of stress, the baby is probably going to be under stress as well, because the baby is feeling everything that mom is feeling. And then if there's also something going on where the placenta, something's going on with the actual umbilical cord or something where oxygenation is not really that great with the baby. And then we look at this ball valve effect that ends up happening. So a ball valve is just something that they describe in any industry. Like say you got a company that manufactures some kind of valve. And to get that valve to open and close when it needs to, they would probably use like some kind of like a ball bearing. And that ball bearing would just, when it needs to close off the valve, it'll literally move and cover the end of the valve. And then when the valve needs to open, then the ball bearing would end up shifting to allow whatever needs to pass through. So the meconium in this example would be like that ball bearing. And what happens is here's the meconium in the lower airway. And right now, this is exhalation. So really, all this air is not allowed to leave because of the meconium stopping. And then the next breath, the ball moves or it shifts, and that allows more air to enter into the alveolus. And then on the exhalation, it shifts back into place again. So just that moving back and forth would mean that you're getting more and more air trapping. And as we know, that could ultimately lead to a pneumothorax. And then with meconium aspiration syndrome, it could even cause some problems with your overall, like your fetal shunts, like your ductus arteriosus. It could essentially end up forcing that to start to reopen again. And so that baby could end up with persistent pulmonary hypertension of the newborn. And this is something that we'll talk about in, I think we're going to talk about it in the cardiac chapter. So then we look at the x-ray, and again, I'm just using the same images that we were looking at in radiology chapter. So what would you expect to see? You expect to see, well, first of all, before you even look at the x-ray, it may be obvious. There's that yellowish kind of color going on with the skin, and we're not talking jaundice. We're talking that we could literally see something underneath the baby's nails. And that's like usually meconium, and it's all on the actual umbilical cord itself. And then when we look at the overall quality of their umbilical cord, you may not see that much Wharton's jelly in there. After being born, you know, sometimes they're going to be born not really doing anything at all. They're going to be kind of like limp and floppy. And then other times they may be kicking and trying to scream, but a lot of times they may just end up needing some help. So they're going to end up in definite respiratory distress. And then if you were to listen, breath sounds on the affected side, the side is mostly affected for sure, you're possibly not going to hear much because of all that air trapping. And also, if you look at the x-ray, you see like what they're saying here is an increase in diameter between anterior and posterior. So your increased AP diameter is just representing that there's a lot of air trapping that's going on. So again, this is the same film. The chest tube is in place. This is the pneumothorax. This is what's happened. Unfortunately, all this patchiness that we see is the meconium itself. So in some areas, it's literally creating like a ball valve effect, which ended up leading to the pneumothorax here. Then how do we prevent this from happening? Well, there's not much you can do as far as prevention unless, say, make sure that the baby is delivered on time. Meaning that if you have a post-term baby situation, so you've got someone who's well past 42 weeks, by that time, there's a lot of stress going on in utero. And the more stress, there's going to be more meconium being produced. So then I guess that's one thing that we could think about is just making sure that you don't delay delivery for whatever reason. And again, that shouldn't happen. There should be no reason why a pregnancy should go that long. And then we look at our guidelines and we say we take that bulb syringe and we try to do as good of a job as we can to try to get the meconium out. And then we just kind of go through the rest of our routine as far as making sure they get enough oxygen. And if it's severe enough, you may have to intubate them and place them on the ventilator. And because of what the meconium does to the baby's natural surfactant, you're going to have to consider giving surfactant. And then in really extreme cases, again, we have the potential for doing ECMO. So if your facility isn't equipped to do ECMO, the baby will definitely have to be transferred to another facility that can do ECMO. So PPHN, or persistent pulmonary hypertension of the newborn. So here's where it shows up. It's not going to necessarily be, I think it's mentioned maybe briefly in the congenital heart defects chapter, but PPHN is just that. You've got a lot of pulmonary hypertension going on still because the baby didn't transition properly, or maybe shunt started to open up again for whatever reason, like in the case of MAS. That forced like the PDA to start to open up again. Sometimes they call it just PFC, which just stands for persistent fetal circulation. Now, to me, I feel like this is the correct term that is describing what's going on. It's persistent fetal circulation, even outside. And then the PPHN is kind of like here's something that's going to develop because of this. The baby's going to end up with a very high pulmonary pressure, at least on the pulmonary side, it's going to be really, really high. Sometimes I don't quite understand why this happens. That's why it's just saying here, sometimes it's idiopathic in nature. And other times, that it was probably one of these things that led to it. A really bad case of really bad infection or some other kind of congenital heart disease caused, again, these shunts to reopen. And there's our meconium aspiration, there's our respiratory distress, and that's something that could definitely lead to this happening. And mostly, if there's any kind of like issue that's going on with the baby that's going to create a case of extreme hypoxemia and hypoxia, then that's when those shunts will usually start opening up again. And then the last point here is like, what if your pulmonary vascular resistance never dropped like it was supposed to in the first place after the baby took that first breath? Then if that never happens, then just expect there to be persistent fetal circulation, or PPHN. Now, what do we see? You see, these are definitely the blue babies. They're going to have there's going to be obvious cyanosis going on. And you keep going up on the oxygen, but they're still not showing any improvement. And saturation is still not really improving. Color isn't changing. They're working hard. So they got all the classic signs of increased work of breathing, the retraction, the grunting possibly, if they aren't already intubated or on the CPAP. And then the nasal flaring is also part of that set of increased work of breathing. Look at the x-ray and the heart really will look enlarged, larger than it's supposed to be. And then this last point right here, the gradient between your pre and your post ductal sites. This same picture I included it in the congenital heart defect chapter, and I think we'll spend more time on it there. So for right now, I'm only going to say that if this is our ductus right here, then blood that's traveling from the left ventricle out into the aorta, that's blood that's supposed to be providing oxygen for the heart, and then your upper region, your upper extremities, your head, and then also the brachiocephalic, so like your arm, your right arm. So then that area would be considered before the ductus arteriosus. And then everything else would be like post-ductal. And that's where all this mixing might start to happen as far as oxygenated and deoxygenated blood. So again, I'm not really going to go into this little guy right now until we do get to the heart defects chapter. But just for now, we could just say that anytime the difference between the PaO2 at the pre-site versus the post-site is more than 20, then that could be a clear sign that the ductus is still open and there's still fetal circulation that's happening. So then how do we treat these babies? So we just have to, usually the standard things as far as you're gonna have to always try to keep them warm and make sure that their fluid balance is good. Limit stimulation for sure. And then consider like some type of pulmonary vasodilator, like again, inhaled nitric oxide could be something that would be helpful. Now notice that this little quilt here, some people, at least at the places I work, or at least the main places I work, sometimes family members will donate these little quilt-like things that you can place over the baby's incubator. And this is how we try to like limit the stimulation. We cover up their isolate to try to keep light from getting in, and then also try to like also help with the sound so that there's not too much going on the inside. And then that'll kind of keep them from being stimulated. And I find it funny that if you go online and look for one of these little quilts or whatever they're called, if they actually have an official name, I don't know what the official name is. We should just call them incubator covers. If you look for them online, they charge like $100 or more for one of these things. But I used to find it such a nice gesture that we would always have some family member donating these, and we had plenty of these things to go around when we needed to use them on these babies' isolates. Okay. Neonatal apnea. So apnea, if we say what is apnea, then we say you haven't taken a breath in about 20 seconds or more. But with the babies with apnea also comes bradycardia. So we don't necessarily wait for 20 seconds to say that this baby has developed apnea. So we're saying shorter periods of no breathing. And then as soon as they stop breathing, their heart rate just literally drops. It plummets. So those are like our classic A's and B's that we're always looking to address. So AOP, or apnea prematurity, is something that almost goes hand in hand with a baby who is extremely premature. Their nervous system just hasn't had a chance to fully mature yet. And for lack of a better word, or lack of better words, they just forget to breathe. And sometimes you can just go in and do something like touch them, and then they'll start breathing again. Or kind of like if they're in an incubator, just kind of like shake the incubator a little bit, and then they'll start breathing again. And they make special beds. They call them, sometimes I think companies would call them thumper beds or rocker beds, that would, ever so often, the bed would move or it would kind of shift position, and that would be enough stimulation to remind the baby to start breathing again. And then PB, periodic breathing, what I'm saying, so 20 seconds or less, and then he stops. Kind of like, not necessarily like chain Stokes or buyouts, anything like that, but it's just kind of they breathe and then they have apnea. And there's really no rhyme or reason with theirs. You can't really predict when it would happen. But it's still some kind of form of neonatal apnea, is why it's included here. So again, how does something like this happen? Your baby just hasn't had a chance to fully develop yet and was born premature, like extreme premature. And because they're so premature, they just may not have the strength. And it takes a lot of energy to breathe. And if you're very weak, then you're going to stop breathing. Just as simple as that. And then with the temperature, so here's a baby who looks very comfortable inside of the incubator, and you regulate the temperature to ensure that he doesn't get too cold. Because as we know, any kind of cooling effect that happens with this newborn, then they're going to stop breathing. So these little portholes, and it's probably a better term for them, but when you need to go in and do care, you open up the little porthole to reach in and do whatever it is you need to do. And true, you're losing heat, but you're trying to be quick about it. You go in and just do what you got to do and then close it off again. So that way the environment gets stabilized again as far as the temperature goes. So now the presentation, and then what do we do to treat it? So if it's going to happen, you'll see it happen pretty soon on. It's not something that will maybe a few days down the road the baby starts having periods of apnea. It'll be something, especially in the preemie, it's going to happen probably like in the very first few minutes of birth or after birth. So then we look at why these things happen. It could be part of what mom was not really doing, like as far as the just her general care. She wasn't really taking care of herself, and then that led to, of course, a much higher risk for the baby. Now, when it comes to treatment, it's like a double-edged sword when it comes to A's and B's. A baby who has a lot of A's and B's can sometimes be gently stimulated and he'll start breathing again and his heart rate will go back up. But then some premature babies, if you touch them, they stop breathing. So it could really go one way or the other. You just have to really know the baby and kind of go from there. And still, sometimes you can't really predict what's going to happen. Sometimes you touch a tiny little baby and they're fine and they're not going to do anything. And then the other time you just touch them with just a tip of your finger and they stop breathing. If they're on the ventilator, it's not that big of a deal. So don't worry about, well, what if I got to go in and do something that's related to, like I got a suction or I got to do something. And if I touch this little one, he might stop breathing. Well, again, if they're on the ventilator, it's no big deal. This will be somebody who's not on the ventilator or who's just on CPAP. If you accidentally overstimulate them, then they may stop breathing. But by no means are we ever going to hyperextend or hyperflex the neck. So that's usually something that you're always going to avoid for any baby. And saturations, anywhere from 85 to 95% is good. Anything higher than 95%, you're thinking possibly ROP could develop. So then that gentle stimulation, again, just doesn't take much usually to kind of break them out of that spell of apnea. Make sure we keep the environment neutral for them, thermal neutral for them, keep them warm enough so they're not losing body heat to their environment. Xanthine derivatives, this is just pretty much saying give them caffeine because the caffeine is a central nervous system stimulant. And that's usually the case. They're not going to use xanthines because xanthines themselves are just too toxic. And it doesn't take much of xanthines before you end up with toxicity. But caffeine is something that acts just like xanthines, and that is going to work out a whole lot better for them. And then for those A's and B's that just don't really, that you can't fix by just kind of gently stimulating them, you may have to consider intubating and place them on the ventilator. Air leak syndrome. So here we go again with the air is now leaking out of the airways in some way, and now it's building up in either the interstitial spaces or around the heart or somewhere that it shouldn't be. So that's why it's kind of like considered like an umbrella statement when we say air leak syndrome, because it could be a lot of things that end up happening because of the issue, whatever the injury is that's causing the leak and where the air ends up going. So pulmonary interstitial emphysema or PI, pneumothorax, et cetera, et cetera, et cetera. All these are our major concerns when it comes to air leak. And what happens, maybe some alveoli tore. There's a tear in your alveoli, and now this air is leaking out. And this is, of course, mostly like for a baby who's on CPAP or CMV. And now this air is just being pushed out into this interstitial space or wherever else it ends up collecting. And then the last statement here is like, whatever the pathway is, that's what's going to determine what the baby has ended up developing. Like in a case like a pneumopericardium, Air leaked out of the alveoli, and then it all accumulated around the heart. So what would you expect to see on an X-ray? You expect to see almost like a dark circle encasing or surrounding the heart itself. And then in the case of subcutaneous emphysema, then you would just see a lot of areas of dark in the tissues, like the shoulder area, instead of just seeing like the kind of like little white-ish kind of like consistency or texture, you'd see a lot of dark that would represent air in that space. So then how would the baby present if there is some kind of air leak? Then these are all kind of signs of distress. The tachypnea, running, the blue cyanosis, the retracting, etc. Blood gases are getting worse. I mean, as far as like there's a ventilatory problem and it's getting worse. And if you were to do your transillumination with your light source, fiber optic light source, or whatever you're using, you'd expect to see a lot of air, which would mean that you get like that jack-o'-lantern type of effect. So it may not necessarily mean that this is an actual full-blown pneumothorax. This could be all the air that is showing up that's leaking out into that interstitial space. So that's what we look for so many other details, because just one test can't really completely convince you, or should not convince you, what the problem is. So like if I were just to look at this transillumination and say, wow, that entire left chest is lighting up. So this baby's got a left-sided pneumothorax or a tension pneumothorax. Okay, but what if the trachea hasn't deviated? And if the trachea hasn't deviated, chances are it's not a tension pneumothorax. It's probably PI, which is just air in the interstitial spaces. Now the X-ray on the top here, here's again our classic air leaking that's going on. And here's our ET tube. Here is a radiopaque line that's the other edge of the ET tube. And then here is another tube. I can't see the gap, but this is our chest tube that we've inserted. And looks to be there's just a chest tube on the right side for right now. And obviously, again, look at the baby's head position. As far as like the ET tube looks to be in good position, because there's the clavicle, right? There's the left clavicle. And it's just slightly below the clavicles, but his head, his neck, he's looking over his left shoulder. But overall, we were looking at this film to see how does this look different from what a normal X-ray should look like. Normal X-ray should, again, just look dark. I mean, you should see dark and dark with some streaking in the hilar area, and then also a little bit of streaking in the lungs themselves for all these like little lung markings. But here, clearly, there looks to be something else that's going on. So this could be like those little bubbles of air that are accumulating in the interstitial spaces. So then, if you have confirmed that there is an air leak situation going on, the last thing you want to do is make it worse with positive pressure ventilation. So this is one of those situations where you're going to need to consider ventilating them with extremely tiny volumes. And that's where the high frequency ventilation comes into play. We have high frequency ventilation coming up in another chapter. So this is high frequency oscillatory ventilation. And people will just call this machine the oscillator for short, instead of saying all of this, because this is a mouthful. We'll just say the baby needs to be placed on an oscillator. And then the high frequency jet ventilation. another form of high frequency ventilation, except the machine looks a whole lot different from this one. And there's some other distinguishing things as well that we'll talk about in the upcoming chapter. So very little volumes is the name of the game, because you don't want to make the leaking even worse. And that'll give the baby's lungs a chance to maybe heal, like wherever those alveoli are ruptured, maybe they'll get a chance to heal. And also don't use a lot of PEEP in these cases, because again, that'll be more pressure that's going to cause that tear to open up even wider. And pulmonary hemorrhaging, this should be, I think, our last one here. Pulmonary hemorrhaging, of course, this could be, as we were seeing in the very last of the previous chapter, there could be some kind of maybe traumatic event that happened, and that could lead to some hemorrhaging. And in general, we just say that somehow you've got some kind of internal bleeding that's taking place for whatever reason. And with the very small babies, they are, again, at the highest risk of having the most complications, whether that's lungs or the brain bleeding. So now, if there's going to be some bleeding that's taking place, it may not show up right away. It may take a couple of days, as they say here, 2 to 4 days, and it may start to show up as far as there's like some clinical changes that are taking place. The color doesn't look good. The baby's color, the pallor that they're describing, they're like almost like a complete like whiteout, almost, like you could just tell like something's not right with the color, which means that you look for other things, like there's some cyanosis as well, and then bradycardia, apnea. And as you see, this could be like the baby was okay, and then around day 2, all of a sudden, these clinical changes started to happen. And if he's already intubated, you're suctioning like pinkish kind of stuff out of the ET tube. And that's usually classic for bleeding. And then, of course, along with the bradycardia, you're going to possibly have some hypertension as well. And if you do get an X-ray, what you should expect to see is a lot of white where the bleeding is, where the blood is accumulating in the lungs. So the complete opacification is something that's possible. Like, say the entire left lung is now filling up with blood. On X-ray, the whole left side is going to look white. Then how do you treat pulmonary hemorrhaging? Of course, this is an emergency situation. These babies already don't have enough blood to begin with. And of course, the smaller they are, the less blood volume they have. So they can't afford to be losing any blood, or they can't be afforded bleeding, any kind of internal bleeding for that matter. So we got to think about resuscitation in most cases, because again, this will be like a sudden deterioration. You're not going to just stand back and monitor to see what happens. You're going to have to jump in and try to get them stable. And then if they haven't already been intubated, you're going to have to give them some ventilatory support. Anything like meconium, blood, or just like a near drowning kind of situation where you've got all this water now inside of your alveoli, those are all going to affect your surfactant. And they're going to either just essentially wash out the surfactant, or they're going to cause it to be inactive. It's not going to be effective anymore. So you have to consider giving some surfactant therapy. Vasopressors for, of course, the blood pressure. And for sure, if they're bleeding, you're going to have to replace that blood quickly and get them transfused. All right, so the questions. So we've got elevated diaphragm on the right and a tracheal deviation to the right. What could that mean? And Kevin, I'm going to have to apologize for not seeing that question you had earlier about how deep it went. I don't remember where we were. So if you've got diaphragm that's elevated on the right, and oh, the pen, yeah, at the pen was established. Okay, okay, I see what you're saying. Yeah, so you were making a comment about that. Okay, all right. So yeah, this right here looks to be what you'd expect in atelectasis. So atelectasis means that the lungs are not fully inflating like they're supposed to. And that just means you've got less volume now. So less volume would mean that I guess you can say the lung is kind of shrinking in a sense. And then that would mean that your diaphragm, at least on that side, would be even higher than normally would be because the lung is smaller. And then the trachea is deviating toward the problem because compared to the unaffected side, the pressure difference is going to be greater on the unaffected side compared to the affected side. So I used to say that this is almost like a vacuum effect. Atelectasis almost creates like a vacuum where it's pulling the structures toward it, like it's pulling the trachea toward the problem. And again, really what's really happening is you've got differences in pressure. You got more pressure on the unaffected side versus the affected side, and everything gets kind of pushed in that direction. Or like I said, it works either way. You can look at it as a vacuum kind of effect, or there's still just a difference in overall pressures on the outside. ET tube that is now above the clavicles, what could cause that to happen? Should normally be slightly below the clavicles. D. So extension would mean like hyperextending. So looking back or position the head really, really far back. And that's probably what's happening. So that's the problem with these head positions. And I've just been criticizing all of these pictures that we've been looking at to say, why are these babies not positioned correctly? Because it's causing their ET tube to look to be in the wrong place. So if your head is going way back, that's pulling the ET tube up higher as well. And then if the baby's head is like the chin is almost touching the chest and it's flexed too much, then that's pushing the ET tube down further. Plate atelectasis. Now, plate atelectasis, we didn't have it show up specifically in any of the slides or any of the pictures that we were looking at, but use what you know. And what do you think? You know what a plate looks like. So what do you think the answer here would be? C? Yes. So when you look at an x-ray, sometimes if there's atelectasis, because of the nature of our lungs being three-dimensional, and then the x-ray itself is only showing you 2 dimensions, the atelectasis may show up as just like a little, like a line almost. And they call that, the radiologists will call it plate atelectasis. So you've got a newborn who's still cyanotic, working hard, even though you're giving them enough ventilation and oxygenation. So what do you think this baby has? Do you think the baby has RDS? PPHN. So now remember that your persistent fetal circulation or persistent pulmonary hypertension it's going to happen because your shunts are open again, like your ductus has reopened or hasn't closed like it was supposed to close, or possibly like your foraminal valley is now still open. So that means that no matter what, no matter how much oxygen you give, no matter what you turn your ventilator settings to, as long as those shunts are still open, there's still going to be fetal circulation. And fetal circulation does not work on the outside. And that's why we're going to see the cyanosis. So that's the key here. Remain cyanotic regardless of what we do as far as the ventilator or oxygen. And they're still working hard as well. So that's like classic PPHN. And again, you've got to deal with those shunts. All right. And is this true or false? Is this true? It is true because we know that any post-term baby is definitely at risk of having more meconium because they're ready to be born. And they are just really uncomfortable in that tight space. And that stresses them to the point where they do a lot of pooping in utero. And they are definitely going to be at a higher risk of maybe having the ball valve effect, which is meconium aspiration syndrome. So we've got an analogy here. What fits? RDS and MAS? Yes. So that's kind of like the key words that we want to tie with these type of problems. Ground glass for sure with the RDS, but then patchy atelectasis is something that you would typically see with like meconium. And true, meconium could also create air trapping as well. But as far as this analogy, these two make sense. Okay, so that's these two chapters. Now let's see where we are as far as our calendar. We just finished chapter 6 and chapter 22. If you haven't already done so, make sure that you get midterm quiz 1 completed before midnight tonight. And also, so I can better plan out my day tomorrow, does anybody plan on coming to campus tomorrow?